So I do have the pleasure of introducing our sleep fellow, Dr. Peter Huh. I want to just sort of highlight his journey to this point, which is pretty remarkable. So he was an undergraduate at Cal Berkeley, where he had a minor in music. And one quick thing about Peter is he's a great singer and dancer. So I won't ask him to do any of that while he's here giving us our talk, but that's a little known fact for him that we enjoy at Norwalk. And then he went on and did medical school at Drexel. And then his residency at Kaiser in California. He did a chief residency at Kaiser in Pennsylvania. And then we were really fortunate enough to have him as a fellow in pulmonary for 2 years, critical care at Yale. And then we were able to recruit him back to be a sleep fellow with us where he is now. And I'm sure he's very excited to be finishing in July after all those years and years of training. I think he's a PGY 8 or 9 at this point. And then he'll be working as a pulmonary critical care faculty back at Kaiser Permanente in California. So they're very, very lucky to have him. And one thing I want to mention about many great things about Peter is Peter won one of the highest awards for patient safety and quality that we give at Norwalk Hospital. It's the Great Catch Award. And it really shows how much of an advocate he is for patient care and safety. He actually discovered that BAL aliquots were accidentally filled with sterile water instead of normal saline. And for those of you who are pulmonary, you know instilling sterile water into the lungs is not a good thing. He was able to figure that out before we gave anything to the patient and really did a great catch, and he advocates for patient safety. So today he'll be talking about AHI. He put a lot of effort into this presentation. It's really complete, comprehensive, and I think you're in for a treat. So without further ado, I want to introduce Dr. Peter Hull. Okay, Peter, take it away.
All right. Well, thank you, Dr. Weir, for that great introduction. Hello, everyone. Good afternoon. My name is Peter. Like I said, I'm the sleep fellow at Northwell Norwalk Hospital Sleep Fellowship, and it's a great pleasure of mine to give you this grand round talk regarding Beyond AHI and rethinking how we define the obstructive sleep apnea. And please do clock in for your CME. Here's a CME disclosure. I think. And there will be more information on a chat as we move forward. So today I wanted to talk about this AHI and obstructive sleep apnea because when I was a pulmonary fellow and then I'm doing the sleep fellowship, I quickly realized that there's a lot of discrepancy between AHI, the diagnosis of OSA, their symptom they presenting to the clinic. There was a lot of discrepancy. So it was something of a question of mine for a while, and this was a great opportunity to really delve deep into the origin of AHI and how it came to be, the limitations, and what we can really learn from it, and the different types of methods that we can use to help us understand the complex disease of obstructive sleep apnea. That's what we're going to talk about today. As an introduction, as we know, obstructive sleep apnea diagnosis drives insurance, especially the AHI, insurance approval, CPAP eligibility, surgery outcomes, research, and etc. And AHI is a very binary diagnostic gatekeeper. And in day-to-day practice, we all see patients whose symptoms, risk, physiology really not doesn't really match AHI. And we often wonder, is AHI a good diagnostic tool for obstructive sleep apnea? So as we move forward through this presentation, our learning objective is going to be understanding the limitation of AHI, appreciate the physiology of the heterogeneity of OSA, explore alternative and adjunctive metrics, and translate limitations into clinical decision making. And in order to understand this, the AHI and its relationship to obstructive sleep apnea, I think the historical context is absolutely crucial. And really prior to 1970s, there's an early development of a polysomnograph in 1920s, understanding the brain waves during sleep. And then we established the sleep stages in 30s to 50s, and that was being well established. In 1950s, there's a famous paper on Pickwickian syndrome, the guy who is big, huffing and puffing, daytime sleepiness, and now we understand that is the obesity hypoventilation syndrome, But in the study of obstructive sleep apnea, he was actually one of the first cases kind of describing the daytime sleepiness and the with the nocturnal sleep disturbances. And really, the development, the pioneering of obstructive sleep apnea, really, and then the study there bloomed in 1970s at a Stanford University sleep lab, where not on top of the EEG, they start adding airflow, effort measurements, and oximetry, which really developed into the modern day polysomnograph. And the father of obstructive sleep apnea, Dr. Gimenu, published a paper in 76 with the sleep apnea syndromes and the series of cases that followed after. And he's the one who first time really truly described a sleep apnea. In his 76 paper, 1976 paper, he described it as a cessation of airflow, the apnea, through nose and mouth, lasting at least 10 seconds. Sleep apnea syndrome is diagnosed as 7 hours of nocturnal sleep. At least 30 apneic episodes were observed. And in 78, he created the term the apnea index, which is the total apnea episodes divided by the hours of sleep. Now, the reason this is important is because when this was first published, people were using apnea as an absolute count and apnea index as kind of interchangeably here and there. But obviously, they realized there's a better the apnea index was a better has a better utility because it includes the total sleep time. It's better when comparing different patients with like insomnia and sleep fragmentation, total sleep time, and oxygen desaturation and daytime hypersomnolence. When put to multiple different perspective, apnea index was better than just a simple count. Now, hypopnea was there and it was described prior to this paper, but it was not part of the diagnostic criteria. And, physicians understood that there was, the hypopnea was definitely associated with symptoms of OSA, but it was hard to quantify and it was not complete apnea. Therefore, it was not included. Obviously, when apnea index was first created, there was a lot of criticism too, because it was not capturing the heterogeneity of the sleep disorder of breathing. And we moved to the 80s, and in the 80s, that it was 1983 with Smallwood and the papers are among the first ones to really kind of start utilizing the apnea hypopnea index. And back then, it was much different than the apnea hypopnea index that we use currently because the definition of hypopnea was not yet established. So everybody had their own interpretation of a hypopnea. And in 1984, what they realized is by using apnea indexes greater than 5, there was a lot of high false positive rates when predicting the increasing the health risk and somnolence in age groups. And there was multiple papers publishing stating the apnea index might be good enough for capturing the respiratory disturbances of the sleep. So there was an ongoing debate on which one is the better indicator for diagnosing obstructive sleep apnea. Big controversy regarding hypopnea. In the 90s, we had our first ICSD guideline published by ASDA, and it was describing OSA as more qualitative disease, meaning as it was a frequent episode of obstruction, but there was no quantitative diagnosis. In 93, Dr. Gimino published a paper of upper airway resistance syndrome. He did 48 patients with esophageal manometry and pneumotachometry, and they realized there was clear inspiratory flow limitation, increased respiratory efforts, and cortical arousal. And this is the first time where we kind of get introduced into a concept of RERA. And obviously, when this was first published, the upper airway resistance syndrome, it was also criticized because it was so similar to obstructive sleep apnea that it was almost indistinguishable. And and retrospectively, we think that's because of the thermal monitoring, because the thermal monitoring back in 90s was the mainstream and it was good in detecting the apneas, but there were some limitations in terms of the flow limit, measuring the flow limitations. And when the pressure sensor came about in later 90s, that's when we could really tell the difference in terms of the flow limitation. And obviously, the very famous 1993 Wisconsin sleep cohort study was published. The cohort study estimated 24% men, 9% women, AHI greater than 5. And this later became more standardized diagnostic criteria that really stuck. And AHI greater than 5 is kind of the minimal baseline to be an abnormal sleep. And just to kind of go off of that, a further epidemiological study kind of showed that AHI greater than 15 has been consistently showing stronger clinical associations. And then just to cap it off, the severe OSA criteria of greater than 30 kind of came along because the strong association and incidences prevalence of hypertension in post-hoc analysis was noted. And that was became the kind of basis of our current model of 5, 15, and 30. Uh, 1997, this was the sleep heart health study, the large prospective study on OSA, its relationship to major cardiovascular events and myocardial events. This is a very important study because later studies that we're going to discuss has been stemming from this as a secondary analysis and post hoc analysis. With that AHI, multiple papers have tried to link AHI to hypersomnolence, but it was not very successful. The daytime sleepiness was more closely linked to sleep fragmentation than AHI. AHI only explained 11% of the variance of MSLT. So the struggle was real. The struggle was still there that AHI was not very good in terms of when it comes to daytime sleepiness and association with the symptoms. In 1999, ASM Task Force published a Chicago criteria. When they published the Chicago criteria, this was the first time when we actually start quantifying the diagnostic criteria for apnea and hypopnea. And when they published this, they really emphasized that this is only for clinical research, only not clinical application. But it caused that still caused a problem. The apnea, what they said is that it was a greater than 10 second a complete cessation of airflow, and it distinguished obstructive and central by effort. Hypopnea is greater than 10-second clear reduction in airflow, but the amount of reduction was not quantified. 3% desaturation or EEG arousal. And in this paper, they introduced RDI for the first time, the apnea, hypopnea, and RERA altogether. And this criteria kind of further solidified the cutoff line of AHI greater than 5 being an abnormal number. In year 2000 was the year that published the second edition of ICSD was published by ASM, and they used the Chicago criteria as the main diagnosis of obstructive sleep apnea. Like I mentioned just previously, it was not supposed to be used as a clinical diagnosis criteria, but by putting it into ACST, it started being incorporated into the clinical practice. In 2007, ASM manual scoring as sleep and associated events was published, and during this time, they were trying to further specify the diagnostic criteria of hypopnea, and they made two separate criteria for ASM recommended and ASM alternative. And ASM recommended is a 30% airflow reduction, 10 seconds, 4% oxygen desaturation. Or you can use alternative diagnosis criteria of 50% airflow reduction, greater than 10%, 10 seconds event, 3% desaturation, or EEG arousal. This is very important because this paper was readily used to become the main criteria for diagnosis of OSA, insurance approval, and Medicare and Medicaid approval. So this is where that 3% and 4% came along, and the criteria for hypopnea was really implemented. And then this really further cemented that the AHI number is equal to obstructive sleep apnea disease. Um, in 2007, this is when the home sleep test was really became the main diagnostic tool that is equally reliable for decision making for obstructive sleep apnea. That really kicked it off. Home sleep test was available prior than 2007, but this paper really kind of launched that the insurance companies and the use of home sleep test for diagnosis of obstructive sleep apnea. 2009, with that hypopnea, the three different definition of hypopnea, they looked into the consistency of AHI, but they obviously, because of that, it has a huge variation between AHI when they were using Chicago criteria or recommended criteria or alternative criteria, and it was the difference is pretty apparent. 2010 was there was a lot of secondary analysis, post-hoc analysis from the sleep heart health study and the Wisconsin cohort studies, and that's really when we start to associate a lot of the obstructive sleep apnea with a lot of comorbidities. 2010, there was a paper that was secondary analysis that showed a severe OSA has a strong relationship with stroke, CAD, and heart failure. Undiagnosed OSA had some post-op complications. And in 2012, there was a second manual scoring was published, and they fixed the problem of having multiple hypopnea definition. So they consolidated into one definition, 30% airflow reduction, greater than 10-second events, and 3% desaturation or EG arousal. And this became the foundation of the hypopnea definition that we currently use. In 2014, ICSD-3 was published. ICSD-3 expanded the OSA disease model into the mental, metabolic, and cardiovascular comorbidities, and that book we still use up to this day. And 2017 is when ASM clinical practice guideline was published, and that really solidified the AHI criteria diagnosis of mild, moderate, and severe diagnosis, with AHI being 5 to 15, and 15 to 30, and 30 above. And up until these days, we still use that criteria for diagnosis of AHI. So it was pretty, just based on looking through that history very briefly, we already can tell that a lot of sleep physicians had a lot of questions at AHI. And, AHI was not supposed to be used as a clinical diagnostic tool. It was supposed to be a research tool, but now it cemented itself so hardly into our daily practices and decision making that now it is our common practice to use AHI to diagnose obstructive sleep apnea. So, let's put together some limitations and blind spots of AHI that, a lot of sleep physicians had was having questions about. And the first of them is the equal weight fallacy. The AHI assumes all respiratory events are biologically equivalent. 10 seconds of hypopnea with resaturation, desaturation events counts as one. And that is also equally counts as one for somebody who having 60 seconds of obstructive apnea for 12% desaturation with arousal. As you can see, there's a big physiological consequences differences, but they all count the same. And should they be? Should they be? That's the question. The event duration is ignored too. The longer events, the greater the cumulative hypoxemia, the higher CO2 retention, the larger endothoracic pressure swings. Event duration correlates more strongly with oxygen desaturation burden, hemodynamic stress, and there's a nonlinear drop in SaO2. We all learned that there is the oxygen dissociation curves. The longer the hypoxemia lasts, there is a bigger dissociation happens. Furthermore, during apnea, you have the right RV preload increase, the LV afterload increase. The longer the hypoxemia lasts, there's a vasoconstriction happens in lungs, resulting pulmonary hypertension. These the cardiopulmonary physiology was already described, and it may have some consequences, but this was not really incorporated into it. Desaturation depth, treated as the same. The AHI often fails to predict the cardiovascular outcomes, and while hypoxemic burden does. The hypoxemic burden idea came along in 2010s, in that decade, and it really showed a better predictability of cardiovascular outcome, which we'll talk about further in the later slides. But AHI does not capture this oxygen deer. And the recovery time for reoxygenation kinetics are also not really counted in. The rapid reoxygenation promotes the reactive oxygen species generating sympathetic activation, slower recovery, prolonged cerebral and myocardial hypoxia. And that's a known physiology. Arousal blindness. The events terminating early, what about those? Like the ones that are not reaching 10 seconds, are they significant or not? They're all completely excluded in AHI. The upper airway resistance syndrome, RERA, high loop gain, this can all cause a sleep fragmentations without hypoxia. And the sleep continuity, the loss of sleep continuity really can disrupt the slow wave REM sleeps, resulting daytime sleepiness, but those are not counted too. With arousal, there is the sympathetic surge that is undervalued. The arousal only counts when it was paired with hypopnea. It by itself is not a standalone diagnostic criteria. The physiological cortical arousal triggers the catecholamine release, blood pressure spikes, heart rate acceleration. Repeated arousal leads to autonomic imbalance, sleep fragmentations, and those are not counted. And we see patients with low AHI, high arousal index, and they present with excessive sleepiness or hypertension. Well, then how is that being explained? Speaking of autonomic, the autonomic stress to the body is ignored. So hypoxia, hypercapnia activates the peripheral chemoreceptors. Increasing inspiratory effort activates the mechanoreceptors. And as the apnea terminates, it triggers sympathetic discharge, transiently increasing blood pressure by 20 to 40 points. Heart rate accelerates. And the magnitude of sympathetic surges, varies widely in patients and the nights the individual night that they sleep. So those are not counted. REM dilution. So REM sleep, as we know, has a skeletal muscle atonia. Upper dilator tone is markedly reduced, blunted respiratory response, increasing sympathetic variability. Hence, there are, oftentimes we see a lot of apnea during this REM period, but REM only counts 20 to 25%. And in elderly and certain patients, even less. So AHI dilutes this. REM predominant OSA is independently associated with hypertension and insulin resistance, diabetes, and cardiovascular events, but those gets diluted in AHI in generally. Positional dilution. The supine position increases gravitational airway collapse, worsens PCRIT, promotes longer and more complete obstruction. Overall, AHI may fall into mild range if supine time is limited. So that's a limitation. The total sleep time error, especially with the home sleep test being the mainstream of diagnosis these days, cannot reliably detect sleep onset latency, awake after sleep onset, microarousal brief awakening. Hypoxemic burden is not captured. Like I said, it will be further elaborated down the road. What hypoxemic burden is basically the depth of desaturation, the duration of the critical oxygen tension, and kind of finding out the area under the curve and its association with the cardiovascular disease. And AHI does not describe hypoxemic burden and which we'll talk about it a little bit more. So, those are the just general the parts that are being missed in AHI, and in population studies, there are a couple we find out there are key distinctions between couple populations. For example, like women, there are more hypopneas in women. There are less oxyhemoglobin desaturation. 2 to 3 times more likely than men to have a REM predominant OSA, and they have a greater impairment of daytime impairment with substantially lower AHI compared to men. They tend to have more. They tend to have more re-rest too. How about in elderly age greater than 65? Higher events counts, but they tend to report less daytime sleepiness compared to other population group. Um, the apnea hypopnea in older adults are shorter in duration, with a smaller oxygen desaturation compared to the other group, lower arousal threshold, and AHI correlates poorly with the incidence of cardiovascular disease once adjusted with their comorbidities and age. Some other risk factor groups like heart failure and stroke, they have central sleep apnea, chain Stokes respirations known to have a poor outcome. Central obstructive sleep apnea physiology is very common in this population, but those are not well fleshed out. So we looked at the limitations, certain populations. How about how about clinical correlations and outcomes? Because with AHI available, we're bound to look into its associations with risks and outcomes, and the correlation was not very good. Obviously, the first thing they looked into is a daytime sleepiness because that's by far one of the most common symptoms that obstructive sleep apnea patients presents with, and the association is very weak. When they looked into the subjects and compared it to the Epworth sleepiness scale and Pearson-Spearman correlation, when it was only 0.05 to zero point 0.2, and just for clarification, this correlation, when it closest to 1, it's a positive correlation. When it's close to 0, there is no correlation. So it's a very weak correlation there. And when they looked further, this was the high AHI are not always sleepy. About 40-60% of severe OSA patients are not sleepy. And and then the standard deviation of the Epworth scale is pretty big. There's a lot of overlap between patients with low AHI and high AHI. Women, even significant, there was no significant trend in Epworth score across the AHI criteria. And yeah, and multivariable. So there was the Apple's cohort study was performed to look into this, and multivariable analysis was done. And the this includes the arousal index, hypoxemic measure, depression, insomnia, and everything. And AHI, there was no independent association with sleepiness or cognition. And when adjusted to everything, the regression coefficient was basically close to zero. What that means in more easier term is that every 1 point increase in AHI, there is almost zero increase in Epworth scale. So the association was fairly poor. Cardiovascular risk with the sleep heart health study, it's important that we look into the cardiovascular risk and its association with AHI. And AHI assumes that every event frequency is the primary driver of cardiovascular risk. However, physiology data, we understand very well that there's a depth of desaturation, time spent in hypoxemia, the insults and cycle are even more strongly correlated with the cardiovascular risk. And it's obvious that we should link this to the diagnosis. The individuals are with highest hypoxemic burden have a significant increase in cardiovascular disease and mortality in the paper that I will further elaborate in later slide. Um, and in a paper in 2009 by Dr. Punjabi is that when they looked into the all-cause mortality with sleep apnea, the mild and moderate had pretty much no significant association with all-cause mortality when compared to no general population, and only severe greater than 30 equal to 30 hazard ratio was 1.46, and the one that had the strongest hazard ratio of 2.09 was the men with 40 to 70s with severe obstructive sleep apnea with AHI greater than or equal to 30. REM-specific AHI showed a stronger correlation to incidence and prevalence of hypertension. People with non-REM AHI and then twofold increase in REM AHI was used as a kind of diagnostic criteria, and the odd ratio was 1.24, which is the 24% higher odds of prevalence of hypertension when adjusted to everything. So the clinical outcome was very not super promising overall when you use AHI, and there's other variables that are being introduced throughout the years, and seems like that's been indicating a better outcome correlations. So that's been going on, and we have to kind of somewhat talk about the night-to-night variability of AHI because the multiple studies demonstrate 30 to 50% intra-individual variability across the night, and it swings the diagnostic criteria from normal to mild to moderate, depends on the day that you actually measure this patient. So, and obviously, an alcohol medications are significantly worsens upper way collapsibility. So, the position also amplifies AHI and in milder disease. Nasal congestion worsens rera and hypopnea, not specifically apnea, but it was all well studied that, the nasal congestions can worsen the outcomes. And REM sleep is a high risk state for upper airway collapsibility. So, we kind of understood there's a limitation. We understood there was poor clinical outcome, and AHI swings a lot, depends on the day or condition of the patients. All right, then, but one way or another, we still diagnose them with AHI, and we decide to treat them. All right, so then is the treatment helpful, and is it good to rely on AHI for this treatment? Not necessarily. And as we move through many years of data, there was a lot of mismatch was happening when we were using AHI and relying on them for treatment. So, first of all, CPAP eligibility paradox, right? Because AHI is very binary. So, if somebody is very symptomatic but AHI is less than 5, the insurance don't approve their therapy, or we may not treat them completely. They're asymptomatic and AHI is greater than 15 or close to 30, and that's a mandatory therapy right there. So that's a bit of a paradox that we're in. And, so when we did that, did it bring better outcomes? But not necessarily. When we looked into SAFE trial in 2016, the CPAP really did not reduce cardiovascular events in asymptomatic patients in moderate to severe OSA. ISAC studies showed a no reduction in recurrent cardiovascular events post-acute coronary syndrome after treating OSA with CPAP. So even the treatment had no very good outcomes when diagnosed with AHI. So we're leading to these three mismatches: the symptom, the treatment mismatch, the risk and treatment mismatch, the physiology, the treatment mismatch. And we're still trying to guiding our treatment and the therapy through AHI and knowing these limitations. Just briefly touching upon the surgery, because those are important part of treating OSA and oral appliances that we describe and talk with patients, right? Because in surgical world, AHI is an event frequency score, and it really does not capture whether this therapy will work. Will this surgery or this appliance will it work? Because we understand now that there's the anatomy of a collapse, like which part is collapsing more? Is the palate? Is the tongue base? Is the epiglottis? The upper airway collapsibility, the peak crit, is very different between patients. Endotypes, loop gain, arousal threshold, the muscle responsiveness are also different. The state depends on the REM sleep, supine, um, severe desaturation. These are all very dynamic part of the upper airway, and AHI very simply simplifies this. So in MAD for Dr. Lee's paper in 2022, when people with severe obstructive apnea were given MAD, they were able to bring down AHI less than 10 for about 50% of the people. And through this paper, they realized that the supine predominant phenotypes are likely had a better response. And then the people with a low CPAP pressure or was independent predictability for MAD responses with area under the curve of zero point 0.6. Not fantastic. It's poor to fair when it comes to a cutoff of CPAP pressure 14. But it was still significant data point. And anybody with a CPAP of greater than 14 have 94 to 95% sensitivity of non-responders. And at the conclusion, it says AHI alone is insufficient for MAD responders. Just to pile on top of that, Dr. Sutherland's 2014 paper showed that the CPAP pressure were significantly lower in MAD. Responders generally have like 9.7, non-responders 11.7, plus minus there, and area under the curve was 0.74, a little better. It's good association, and cutoff was 13 that they used, and 100% negative predictive value for non-responders. How about upper airway surgery? The UPPP, Dr. Choi published a paper, meta-analysis. Preoperative AHI was not a significant predictor for UPPP. For maxillomandibular advancement therapy, the higher baseline AHI did not end up with worse post-op AHI compared to the lower AHI. The AHI alone limits a predictive value of surgical outcomes. Um, Also, the hyperglossal nerve stimulation, the famous trial. The responders were identified to be the lower loop gain, the lower collapsibility, higher upper airway muscle responders are the ones that responded the best to the glossal nerve stimulator. And the baseline AHI showed no significant association with responses. These endotypes, when they put the endotypes based model, the area under the curve was 0.7 to 0.8, which is good to great. But when they only use the AHI, the area under the curve was near chance, and zero point 0.5 is near chance. So now we kind of talked about this AHI has limitations. It's not has very the correlations with the other metrics was poor. Clinical outcomes very questionable, and we are deriving the treatment, also it has no good outcome research and also not very good predictability of outcomes. So it is in our natural tendency to try to find something else. What else can we use as a metrics? What else can we use to understand OSA and diagnosis and treatment? The first one was the hypoxemic burden, and this paper was published in 2019. Dr. Azabarzin. This paper used the cohort of the sleep heart study and Mr. OS sleep study, and putting it all together about 8,600 patients following for 11 years. And they used the hypoxemic burden definition as total area under the curve for oxygen dissociation curve. And a desaturation curve and expressed as a percentage minutes per hour. The primary endpoint was cardiovascular disease related mortality, and second endpoint was all-cause mortality. And he divided into five different quintiles for this population. And when fully adjusted and everything, they has a ratio for high quintile, the 53% and above, were having a hazard ratio of 1.81, 2.73 with good power. And sleep heart health, also those two quartile had some hazard, an increased hazard ratio for cardiovascular risk. And all-cause mortality, the Mr. OS cohort had some hazard ratio in a high quartile patients, but sleep heart health really did not show that. And then they also showed that AHI had no independent association with cardiovascular mortality. So the hypoxemic burden it was a better indicator for cardiovascular outcome. TST-19 is the time spent below oxygen threshold. So in 2009, Dr. Punjabi also used a sleep heart health cohort and did all-cause mortality comparison with the percentage of total sleep time. And this was less than 90%. And he also did a four quartile system, and the upper quartile was greater than 2.7% of total sleep time. And what he found out is men less than 70 years old, the TST90 was strong independent predictor of death. When they compared the high quartile versus all the other together, there was hazard ratio was 1.83. Different paper, Dr. Kurzani in 2024, secondary analysis of another sleep health, heart health study, looked into the mortality risk, and this time he looked into the percentage of sleep time for 85% and minutes of sleep in 85% as well. And they, in both cases, the longer the duration, the longer the percentage, the longer the minutes, there was a higher association of mortality. And this was just an abstract, but then I found the Dr. Miyakuta in 2023. They compared a TSD90 versus TSD80 for cardiovascular risk, but the TSD80 was not superior in terms of predicting cardiovascular risk. Um, that's a hypoxemic burden, TST90, and what about event duration? Dr. Butler used the sleep heart health secondary analysis for the duration, and they also did a four quartile system. So the apnea duration, the shortest one was 11 seconds to 17 seconds, and the longest one was 24 to 57 seconds. And when shortest one and the longest one was compared, the hazard ratio was 1.31 for all-cause mortality. Arousal index. This was a study in 2021 in China. 10,000 patients were looked into with the arousal index, and they used a quartile system with the arousal index of 45 was being the highest quartile, lowest one being 16, and this is the arousal events divided by per hour as a unit. And every 10 events per hour increased the arousal in arousal index, and the odd of hypertension increased. And as you can see, the value is not super high. The total cohort and OSA subgroup odd ratio is not super high, but it's at least statistically significant. And sleep fragmentation itself contributes to the cardiometabolic risk. This is a different one for arousal index. This is Dr. Kim's paper in 2019. This is OSA and arousal index and compare it to the sympathetic overactivity. I briefly mentioned that there's a sympathetic overactivity happen in physiology during sleep apnea, and how they're going to measure it was a key, and they measured it by heart rate variability process. This is using EKG, and from different frequencies of EKG, you can kind of deduce the sympathetic of activities, and the low frequency and very low frequencies are associated with the sympathetic dominant signals, and high frequencies was parasympathetic the signals. And what they realized in severe OSA, the low and very low frequency that is sympathetic or increased. Frequencies were increased, and when they did the regression coefficient, AHI was 0.234 for frequency wise, and an arousal index was 0.266. So what this means is that in every one value increase in arousal index has a more significant impact in terms of increasing in lower and very low frequency compared to AHI. So this kind of shows what this shows conclusion wise is repetitive arousal has a stronger drive for autonomic dysregulation rather than seeing AHI alone. REM AHI. So Dr. Mokolesi in 2014 used the Wisconsin sleep cohort. And then REM AHI showed a dose responsive relationship for hypertension. REM AHI predicts hypertension independent of non-REM AHI. The REM AHI greater than 15 versus 1, odd ratio was 1.26, and pure REM AHI with the REM AHI greater than 15, odd ratio was 3.3638. So there's definitely a high chance of having high odds of having a hypertension with increasing REM AHI. Different paper, the Dr. Shami's paper using a heart health study. This is the paper that relates a REM related sleep disorder to the glucose intolerance and insulin resistance, and the REM AHI independently associated with insulin resistance. The beta coefficient was 0.04 per log units, and increase in AHI, REM AHI. What that means in more simpler term is that every 2.7 increase in REM AHI, the insulin resistant increase by 4%. And this correlation was seen in patients with a BMI greater than 27.6. Um, so this was an interesting paper. The positional OSA. So this is Dr. Kang's paper in Sleep Heart Health. This is strictly looking the positional OSA, defined by AHI greater than 5 and supine in supine AHI at least twice as high as non-supine. And it also looked into exclusive positional OSA definition, which is the AHI resolves with change in position. And they followed it for 8.4 years. And the positional OSA have lower cardiovascular risk, lower risk for cardiovascular events compared to non-positional OSA. But no significant trend was noted when looked into the exclusive position. So we looked into the different metrics. So we looked into different metrics, variable metrics that that was looked into for outcomes and assessment of obstructive sleep apnea. And there was substantial amount of data that shows there's a good correlation and outcomes and risk factors. So how can we utilize this? How can we think about AHI now? Like what should we do? What do we do with OSA? So, diagnosing OSA using a multi-dimensional model is important because OSA is not a single disease. And I think I made that point fairly clear up until this point because, AHI is not a phenotype, meaning that, OSA has symptom part, which is, patients come in with daytime sleepiness, cognitive impairment, mood symptoms, physiological and injury mechanisms are there that we understand the hypoxemic burden, arousal burden, REM position, ventilatory control. There's a comorbidity risk factors with pre-existing conditions like hypertension, AFib, heart failure, and these events were not needs to be assessed as a quality, not quantity, because there's a way more into the process of the apnea in obstructive sleep apnea. So where does the AHI stand, really? I mean, it's useful, ironically, after 60 slides of bashing AHI, it's obviously, it's interesting, but AHI is somewhat useful. It has saving grace because it's a starting tool. It's identify patients with abnormal breathing during sleep, and it can be used for research purposes and establishing kind of the baseline of disease presence. But we all know it's not complete. It needs a little bit more. Um, so where do we go from here? And the multidimensional the severity score is needed. So, we talked about the hypoxemic burden, we talked about arousal index, we talked about sympathetic overactivity, we talked about REM, position, and TSD 90 and all these things. And they showed on their own showed a various different outcome data that is superior to AHI. So perhaps we need a severity score model that includes all of them because like we do other tests like CPAT or PFTs, and these things we look into multiple different values and different perspective and different directions. Why not OSA? Because we already know OSA is a very heterogeneous disease, and it needs to be looked into multiple different ways to have better outcome, better assessment, better treatment outcomes, and overall personalized phenotyping because CPAP is not the only treatment option. We have airway, we have a hypoglossal nerve stimulator, we have surgeries, and upper airway collapsibility, arousal threshold, loop gain, upper airway muscle responsiveness are all important factors, and they all are needed to be a little bit more streamlined and a little bit more specifically specifically organized so that we can kind of do a better outcome studies. And of course, what kind of presentation would it be without AI being mentioned in 2020, in 21st century? And I think AI would be a very interesting model to be incorporated into this because, nowadays we still use AI to help us to kind of use in PSG and understanding the kind of help us with the diagnosis. But there are far more utility with AI if we start using the multi-dimensional scoring system because there's going to be a lot of variabilities and a lot of variable numbers, and I think AI could definitely take in part in terms of those interpretations. So overall take-home points. Um, so thank you for kind of like staying through all this, and it's a lot of data within a short period of time. But my take-home point is OSA is a heterogeneous disease, and AHI is a starting point, not a diagnosis. It's convenient, but not comprehensive. Event frequency is not same as physiological burden. Symptoms, physiology, comorbidity risk must guide the diagnosis, treatment decisions, and therapy selections. And we should always treat the patients, not the number. And that kind of summarizes my presentations, and I really thank everybody to stay with me for a whole hour. I'm really curious what our other more experienced sleep doctors think about AHI and where this direction is going and what we can do to kind of improve our diagnosis, treatments, and the next steps that we should take. So, thank you.
Great, Peter. That was absolutely fantastic. Very comprehensive. Lots of information to digest. So we can certainly have people unmute themselves and give any kind of comments they have, questions for Peter about how your thoughts are with what was discussed about the limitations of AHI. While we're waiting for everybody to jump in, I'll just ask a question. So Peter, the sleep world has been sort of subject to a lot of negative therapy trials, specifically regarding CPAP. And, like you mentioned in some of your slides, we're using AHI to sort of distinguish that. And we're looking at, maybe something as such as cardiovascular outcomes. So if let's say these patients are not sleep, because I think most clinicians would say any degree of sleep apnea in a sleepy patient warrants a treatment trial. But if the patient's not sleepy, is there anything in your research that you think could maybe be subject to further research and predicting cardiovascular outcomes for these patients? And so, right, we have things, yes, we should treat them, but what about patients like that we say, no, we shouldn't treat you, right? Because we're just using a strict AHI. So you may get a mild patient with hypertension, and we're going to probably treat that, but they're asymptomatic. You may also get a moderate patient who has no cardiovascular risk factors, and comes to see us because spouse was upset about snoring. So is there anything that you think would be maybe better than AHI that could help predict cardiovascular outcomes?
Probably, it's a great question. I think it's probably the hypoxemic burden seems to be most promising at this point with the cardiovascular outcome study wise, and I think it's a tough question because as a physician we treat patients and we always wanted to make sure what's best for the patient and we don't want anything bad happen to them, and we always err in the side of caution and try to treat them first and hope for that if it comes to great, and if it's prevent them from having a cardiovascular event or hypertension or AFib, hey, that's great. If it doesn't really come to that end and it felt the same way, oh, well, we tried, and at least I'm not faulting for being treated. I think that's always like a little bit of a doctor's dilemma and always but in current setting. So those are I think the tough decisions are usually the people who are like mild to moderate OSA with very questionable cardiovascular outcomes with AHI, and those are the ones that are I'm probably have a difficulty. Well, those are the gray zones that we're always kind of, is this worth treating? And we're actually looking for other factors to really justify our treatments, like like sleepiness, depression, and other metabolic disease and obesity and all that. And I think that has been guiding us in terms of treatment wise. But with these new metrics, I think we can really, if we can kind of hone down on some of these and make it a little bit more systematic, I think that would be really helpful moving forward.
Great. So we have a bunch of congratulations on an excellent talk from Norwalk and other colleagues. Appreciate that. And then I'm just going to read here. If we were lab medicine docs, we'd be interested in what distribution of individuals without known apnea by AHI looks like. Is there an apparent cutoff value of normal? What does, like for example, the 95 percentile fall? So yeah, we just have this AHI less than 5, and we tell patients they don't have sleep apnea. But are we really sure that those patients don't have sleep apnea?
Hmm. It's a great question. We don't. We won't. We'll not know because it's a wild west in that category, right? Because we know that arousal, we think the RERA, the upper airway resistance syndrome, definitely some part is causing some issues here, but we don't have like clear-cut diagnostic criteria like AHI to really put our fingers to it, right? And sometimes we just need to make one. I wonder sometimes, even as naive as it sounds, and sometimes need to just make one and to see what sticks. Like just like how apnea index was first made and everybody bashed on it for not being comprehensive and all that. And ultimately, we ended up with using it at the end, and they just build upon it. And well, I'm wondering if that kind of new score or new metrics is needed in those areas, and that is currently being gray.
Yeah, and I think it brings up a good point about, false negatives. So you sort of mentioned about the night-to-night variability, and most home studies are going to do one nights. There are some devices that can do multiple nights. We do an in-lab, it's one night. It may not sort of indicate their specific sleep environment at home. So, I think that's important if you have a normal AHI, especially on a home study, of course, you're going to repeat an in-lab study or multiple night home study if you have a high clinical index. But yeah. And then, as you mentioned, the patients who have like a normal traditional AHI, but they mostly are RERA dependent, there are some insurances that won't cover RERAs, and those patients, if they're symptomatic, we have struggled to treat those patients. So yeah, these are all really good points to bring up. Um, Anyone else have questions? Otherwise, I'll keep on going. I could. So one thing I liked on your data there was about the prediction of oral appliance success in patients that are previously on CPAP, or you have some idea about their CPAP tolerance. Because again, speaking with your AHI, we typically say, oh, mild, moderate, dental device, that's going to be second line if they can't tolerate a CPAP, or sometimes even first line. But it's good. It's really good information that I really wasn't completely aware of about, looking at if they're on CPAP and they require high pressures, that sounds like it's a high prediction rate that they're not going to be able to tolerate, at least from an AHI perspective, again, using that as a metric, a dental device. So that was an interesting point that I haven't heard too much about previously. And I think,
Yeah, I agree. Yeah, it's like because like we see like large patients who look like they may have like very severe obstructive sleep apnea and they really don't, or there are patients who are very thin and looks okay, but their pressure requirements are very high, and that all comes down to like their airway collapsibility, and the oral appliance helps, but it can only do so much if the collapsibility is too much, and it won't work. And sometimes I think that's the surrogate understanding of measurement of this collapsibility is probably the CPAP pressure. And I wonder if that's like you said, it may be very helpful just to know where what if we already know the pressure to begin with, the offering MAD or as an alternative treatment would be a little bit more there.
Great. We have a really good, I love this question because I think it really sort of, very good presentation and your point of view of OSA. If you're not going to use the AHI, what do you think are the disorder defining criteria?
Uh, Defining criteria.
We
Wow,
bashed it, but what else are we?
that's a if I know that I would be in somewhere else making a lot of money. But that's a hard question. I think Dr. Zincher, you asked me the question that you have for a long time, but I think I don't know. I really truly honest with you, not sure because I think these different the adjunctive diagnostic criteria are there to kind of looking into like slightly different things on these whole papers and kind of we may need a study that kind of look into like a cumulative or like two, three indicators putting it together. So to be honest with you, I'm not too sure. I think depends on what you're kind of trying to focus on. If it's a cardiovascular risk or is it the overall risk or is it overall mortality? Is it the insulin resistance, stroke risk? Like depends on what you're looking at. I think that's these criteria can be a little bit more it'll be different the way I look at it. So I don't know.
Anyone have
Yeah,
any
no,
comments about that? And then the next question was, in terms of the hypoxic burden, any data on the supplemental oxygen
Yeah.
OSA treatment with those with hypoxic burden? Does that any data
Mhm.
on long-term cardiovascular outcomes?
That's a great question. I actually did not look into it, so I don't know on top of my head that study, whether that kind of study was done. I wonder if anyone else knows, if that was ever attempted or ever thought of being launched. I think
sure.
that's an interesting
Yes,
idea because yeah.
I can answer a little bit on that. There is not a tremendous amount of data in in sleep apnea that's obstructive. There's some data from central sleep apnea in people with CSA and hypoxemia who were treated with long-term oxygen therapy. And that study ended early because of recruitment problems and COVID, et cetera. But that study actually showed a signal for harm in giving people oxygen, specifically mortality and cardiovascular events. And in obstructive sleep apnea, there's a few studies that looked at mechanistic impacts of giving oxygen to people with obstructive sleep apnea to see, if you get rid of hypoxemia, are you improving blood pressure? Are you improving symptoms? And it does tend to improve sleepiness a little bit, not as much as PAP therapy, and it improves blood pressure to a smaller degree, but it was not an effective treatment for OSA.
Yeah, those are great points. And like one of the things we sort of struggle with in the clinical world is, a patient has severe sleep apnea and they can't tolerate a CPAP, and
Yeah.
some usually PCP or the hospitalist will just give them some oxygen therapy, and that's better than nothing. And like, as mentioned, there is some data that it can reduce sleepiness and may have some mild effect on the AHI. Although again, it's sort of like you're defining AHI with the hypopnea anyway with the desaturation, so you're sort of like that, is that really meaningful? But my concern is that, is that if you, one of the things that sort of tells your brain to start breathing again is obviously the CO2,
Yeah.
but also the
Yeah.
hypoxia. So if you blunt the
Mhm.
hypoxia drive, could they have a prolonged apnea? And, I've actually seen that clinically. When I have a study that I always pull up that showed that the apneas, I had one half of the night was a diagnostic study, and the other half of the night the technician put oxygen on the patient because they were discharged from the hospital with it, and the patient insisted. And again, it's just one night, and the things happen different times of the night. But the apnea duration was much longer with the oxygen, and like significantly longer apnea duration. So could that over the time potentially increase, overall hypoxic burden as we, as you sort of divide it with the area under the curve, and potentially be worse?
Mhm.
So yeah, definitely, oxygen. I think I really discourage oxygen therapy in patients with moderate to severe obstructive sleep apnea as a alternative to CPAP. And that central apnea paper was really interesting as well. So that sort of has kind of have an impact on my overall practice in central sleep apnea, where I used to try some oxygen in the beginning, but I kind of moved away from that. So those are great questions. So I think we're actually perfect at 3 o'clock. Great grand rounds in presentation. Really appreciate it, and hope people can join the pulmonary grand rounds, which is starting now on interventional pulmonary. So thank you, everyone. Thank you, Peter. Thank you, Yale, for having us, and everyone have a great week. Take care.
Thank you. Bye.